Thanks, Fasad, for the nice introduction. Again, hello, everybody, everywhere. My name is Omar, joining from Dublin, Ireland. It's my pleasure to join the webinar today, and I'm very delighted to welcome two of our distinguished colleagues that are joining us from the beautiful, fascinating Caribbean island of Puerto Rico, Dr. Gloria Rodríguez-Vega and Dr. Ricardo El Garcia. Thanks for both of you for the time and effort. We welcome both of you. Gloria and Ricardo will share us their transatlantic experience about the topic of the hour, which is COVID-19 in both adults and pediatrics. I would like also to express my warm welcoming and thanking to all of our audience tonight or today attending the webinar. And please feel free, if you have any question, just write it down in the Q&A partition and we'll do our best to answer it. Well, because ladies first, we'll go with Glori, introducing her, and then she can share her screen later on. So Dr. Rodriguez's area of interest is internal medicine, intensive care, and neurocritical care. Gloria was graduated from Cornell University and Central University of Caribbean, and she completed her internal medicine residency in the Veteran Affairs Caribbean Healthcare System, and she had later on the critical care fellowship in the Miriam Hospital at Brown University. She went back home again to Puerto Rico, spent many years in surgical intensive care and neurointensive care as well. She is currently the chief of the Department of Critical Care at HEMA San Pablo Cagos Hospital, and she is also involved in many intensive care societies, has many publications, and co-editor of the book named Critical Care Administration, a comprehensive clinical guide. Thank you very much for joining us. And I have a little question. If I'm visiting Puerto Rico, when would you recommend me to go there?
That is an excellent question, Dr. Omar, and you can come anytime you want. Right now, it's a place where we have a high vaccination rate and a low COVID transmission, and I know COVID is the topic of the hour, so if you're vaccinated, come over and visit this glorious island. Now we have a tropical weather all year long.
Thanks a million. The floor is yours, and you can share your screen. You already shared. Yeah, thank you very much.
Thank you, and thank you to the audience who are joining in us today, and thank you to Dr. Saad for allowing us to have this channel, the Mega, to be able to communicate with the world and our knowledge, and for him for organizing. Let me see, I'm trying to, here we go. So pandemics are not new to us. This is the plague in Rome. This was to the Antonine plague. This was 165 AD. We know from this current era, the influenza pandemic, this was a very transmissive, 20% transmission vector, 2.5 to 5% mortality. There were a lot of deaths at the beginning. The mortality was around the 20 and the 40s age. And so over the world, there were approximately 50 and 100 million deaths. So pandemics are not new to us. And now so we have our COVID vaccine, this is the one that we are living right now. And as of today, there had been over 259 million confirmed cases and a little bit over 5 million deaths. So the question is, when will this end, if this will end, and how do we get out of it? So what are the lessons that we have learned along the way in this pandemic? There are still some to come. And one thing we know is that some of the strategies that we used 100 years ago, and that is the good thing of documenting our experiences, such as social distancing, hand washing, confinement. We were talking before going live of the confinement, and if we needed a newer one, as newer variants approach, do they work, do they not work? And also we were talking about the use of masks, and these are things that have worked in every pandemic and are the ones that we used at the beginning. The other thing that we know is, and this we can remind us of Einstein, right? If we do the same thing, we will get the same results. I think it's the definition of lunacy, right? To expect different results when we apply the same thing. So that's another thing that we know. So at the beginning, what we learned was, how do we prevent the transmission? And these were the three pillars. One of it was dissemination control, and halting and doing the confinement. One of the things was controlling dissemination when you closed the borders, when you had people to go into lockdown, but it also gave the government, the healthcare workers, time to prepare, because that's another thing that we're going to be talking about later. The being prepared for a pandemic or for a response or for a disaster. There are some topics that are the same along the different types of disasters, but there are others that were new to this pandemic. The other thing is knowing the epidemiology and having good sense of how this virus is behaving and how it's behaving with the population and getting numbers. And the other thing, social distancing. We know for sure that all these type of agglomerations, as they were happening, the one thing, right, from Italy, how it spread into Europe and into the Americas, Milano Fashion Week, there was a place where there was a high agglomeration, a lot of travel. And with this age that we live, traveling is something that has been a challenge. And now with the Omicron variant, we know for sure that this virus is probably already spread and we just haven't identified it in our different countries. So it's something that we need to at least try to control as we trying to avoid these newer variants. How do you do immigration controls? How do you do these epidemiological controls, not only worldwide, but also in your own countries, in your own towns, and taking control of that. Also, one of the things that we learned was the veracity of the information that we were getting. Who do you trust? And what are the different associations that are going to be getting information and trusting? World Health Organization has been in the forefront of this, right? The other thing were the mass events. This was another one in Valencia and in Atlanta, that how do you access the control? How do you keep the distancing? And now in countries that have a high vaccination rate, these things are starting to open, but with certain controls. So at the beginning we were closing. Now that we're opening these events, to these mass events, how do you control them? At least for example, in Puerto Rico, we're having mass events in which they require 100% vaccination to have X amount of seats. If you're not going to require vaccination, but proof of negativity, then you only have half of the amount of seats. So that is something that these events are helping also in promoting vaccination. Stay at home, that was something that we spoke about, confinement and social distancing, but then until when are you going to have that confinement and those lockdowns? We know now the impact of the psychological impact of these lockdowns, how it has been, well, the elderly, with the children, the schooling at a distance, not only the psychological impact, but their academic impact. The same thing is it economically feasible or possible to extend a lockdown and all these social distancing? And we're not talking about standing 6 feet away, is that when you're planning an event or in your restaurants and the economy, having these barriers placed are something that impact economically your own area. So newer strategies on how to at least go down a little bit on these social distancing requirements, as vaccination is proven to be worthwhile, as masking is proving to be worthwhile, then there are certain things that we can start to lower our requirements. Masking, I think, and we were talking about this in the preamble to this meeting, masking, I think, has been essential to try to diminish the amount of transmission of your viral load when people are masked. But this requires a lot of teamwork, and this is something that we have learned throughout this pandemic. With the help of the vaccine, and there are several things that were required for the logistics of coming out with a vaccine so soon. One was a coalition for the epidemic preparedness innovations. These are people that are preemptively planning for these things. NIH running large studies. There were the World Copper. There were more than 100 projects around the world. The Human Challenge trial, where we had humans as volunteers for these vaccines to come up. At least 8 of them were tested in humans. But what were the possible obstacles that we learned with the development of this vaccine in such a short time? And one of them was, how do you demonstrate your effectiveness? How do you control the cost? How do you manufacture enough to supply the world, since this is a global pandemic? And how do you distribute it and guarantee its application in fairness? We know, and we can have anecdotal stories on how these things were not done 100% compliant. The newer challenges, there are several vaccines come up, which ones were purchased by different countries, how were they effective? Now with the newer variants, will the ones that were effective for the Alpha, the Beta, and the Delta, are they going to keep being effective for the newer ones that are coming? Newer studies keep coming up. And then that also goes back again on the possible obstacles as we approach newer variants. The other thing is the requirement of booster vaccines, and how will that end up? Is this going to be something that is going to be required every 6 months? Is this going to be a yearly thing, such as a flu vaccine? As we don't know, right? This will be seen after the pandemic starts finalizing and the newer variants start to stabilize, and not as quickly. I think the most important thing, and one of the bigger obstacles, has been how has it been administered throughout the world? We have countries that are already into their booster vaccines that are including their 5 to 11-year-old population. But as you can see, there are countries such as Africa that are lagging behind, and they haven't even started vaccinating the whole population. So as a world, until we control the whole population and get that population vaccinated, that is something that might be affecting the emergence of several strains, and how do we get out of this pandemic? So this is something that we need to talk about. What are possible solutions? Should we have a vaccine bank? Definitely international cooperation is a must, but who will be leading this international cooperation? Is it going to be the United Nations, the World Health Organization? Is it going to be different governments getting together? What are the future of these, and how do we get into vaccinating the whole world? Financial solutions. How do we, I mean, this is something that is driven by pharmacy. And how do you come up with a financial solution for less able countries to acquire these vaccines? And also the epidemiological surveillance, as we are seeing right now. I keep mentioning teamwork because it is essential on the success of getting out of this pandemic, and also resilience. Resilience from our healthcare workers, and how do we treat our healthcare workers and the response. We've spoken earlier about the government response from a public health policy standpoint, from a government standpoint, from a global standpoint, but now, what have we learned about our emergency response protocols within our institutions? And one of the things is that you can never be too prepared, right? Being prepared is something that has been demonstrated to help with our response to a pandemic or to a disaster. But newer things have come up with this new pandemic, with COVID, and it's the concept of distributive justice. What scores are we going to be using when we assign who gets treatment or not? We saw at the beginning how Italy had their response and how they had to, at times, pick an age and say these people are not going to be treated. Is that fair? Is that distributed justice? Are we going to be using other scoring systems beside age? Productivity? Is it going to be the MSOFA? Is it going to be other type of scoring system on a way for this to be just? And who will make that decision? Will it be the frontline healthcare worker that is already having the burden of providing care? So these are things that we're going to be talking about a little bit. So as we know, when you have a disaster, your command center, and I urge every time there's an event coming up or a seasonality here in Puerto Rico, we have our hurricane season. So before hurricane season, we do a little review of these things, our command center, our communications, how they're going to be. One of the things we've learned, especially after the Hurricane Maria, was that we needed to integrate an ethics committee within our structure. These weren't decisions that we were going to leave to our frontline workers. How do you escalate the type of response that you need? And when do you ask for outside help? Also, the things about equipment, we've talked about ventilators, the need for oxygen, the need for sedation and analgesia, how it came about within this pandemic as we were treating them. How are experimental drugs going to be used? Were they going to be used outside research protocols, or were they used within? And which drugs, because the whole world was using them, so there was a shortage. So how do we repurpose other drugs for these things? So one of the things is these we learned, so we should be incorporating these lessons and what we learned in our hospitals and in our response into our future protocols. There were other elements that are also to be included, and this was one of the example was New York. New York already had a limitation for heroic treatments such as ECMO. They even had limitations when ventilators were not available, when oxygen was not available, and how we're going to quantify that and to distribute it. And as I mentioned earlier, including an ethics committee into this planning to be on hand when these tough decisions were needed to be made and not to leave them for our frontline healthcare workers. SCCM also reimagined their tier staffing strategy. And one of the things is, as advanced practice providers have become commonplace in our ICUs, how do you also increase your demand with these models? And these were very helpful. And these were not made right into the pandemic. These had been developed beforehand in these scenarios, and that's part of the preparedness. And you should get them and have them introduced in your protocols. One of the things we learned is the mortality rate of COVID was not only elevated due to the disease itself, but there was also a correlation on the amount of healthcare providers that were present or available. And that's something very important. The same thing happened in New York. It depends, when you had your higher admissions, the higher was your rate, and also depending on your age rate. So how do you grow an ICU when you don't have enough space? And that is something that this pandemic had made us reimagine the amount of space that we needed, the containment, because of the isolation that you needed, the amount of supplies. How do you adequately grow that ICU in terms of your visiting hours, of the levels of personal protection? And one good example of innovation was Hospital El Salvador in El Salvador. what they did was, this was a former Olympic complex, and they turned it into a hospital with a huge amount of ICU beds and a control panel with intensivists. So what they did was, this was in situ telemedicine with the intensivists here providing care, and then non-ICU physicians or healthcare workers were trained, and we were part of this training into managing these patients at the bedside. But then you had this limited amount of intensivists in doing telemedicine, and that way we protected the knowledge on taking care of these patients by not exposing these limited amount of intensivists that were in El Salvador. So that was a very ingenious way of coming up. But this required not only collaboration and teamwork from the critical care societies and medical societies, but also with the government. That's one of the things. And the other thing was addressing vulnerabilities. After you do have an event, a disaster, you usually have an after meeting. The problem or the lesson learned with COVID is we're still in COVID. So we're still having these after meetings during, as we are overgoing this pandemic. So right now we're talking about the newer variants and how are we going to address this? So you're constantly preparing while you are also taking care of these patients. So that's one of the things with burnout that we need to address. One of the things is preventing the consequences of what we come up with, especially treating a disease for which we don't have treatment. There were you looked at the pathophysiology, you applied certain concepts, certain things were tried, but there were several problems along the way. Number one, the development of a drug requires research, investment, and development. It requires an international cooperation, and also there are certain regulations within different countries that allows you to either research on a certain drug or not. So these are one of the challenges that we have faced, but also with the treatment was the media coverage that we got. And at the beginning I mentioned one of the important things is, who do you trust with your information? There was a lot, and there is still a lot of misinformation that the Harvard Gazette has called the pandemic of misinformation, with the benefits of social media of allowing to be able to communicate faster than in the written form, or having a paper being submitted to a journal, accepted, and then published. But there was a lot of misinformation out there in the media that you had to take over. One of the first things that suffered these consequences was the use of hydroxychloroquine. At first, it was considered something that would be efficacious, and now there are a lot of papers that question the validity and the use of this drug, and now it's not even in the guidelines. The amount of research that came out is something positive, which says that a lot of the things you can do them quicker, getting them prepared, but still there has to be an oversight and some rigorous, as we have seen with what happened in ivermectin, that now we are having recalls of this, retractions from different journals, that things have been published and they have gone through an editorial board, but now we're coming into retraction. So even within, we've spoken about how media had helped with this misinformation, but also the medical community, we have to be very cognizant and stay within the realms of good and proper researching. So is there a light at the end of the road as we finished this lecture? Yes, there is. We have the COVID vaccine, and it's not that I'm a foresighter, it's that we can learn, and we have learned from the past. There have been pandemics, we have come out of them. There have been, with the introduction of vaccines, and also without the introduction of vaccines, there has been pandemics that have been controlled, but mostly thanks to the use of vaccines. From now, one example, it can be polio, it can be rubella, it can be influenza. We have come out, right? But others, such as bubonic plague. A vaccine didn't come out, but we learned about the disease, and then we established strategies on how to get rid of the vector and control the vector. So yes, is there end of the road of the tunnel? Is there light at the end of the tunnel? Yes, there is. We have the COVID vaccine. We've had monoclonal antibodies, and learning from previous viral diseases and from other diseases and from sepsis, we've learned this time is of the essence. So the sooner you start to implement your targeted therapy, the better the outcome will most likely be. So the same thing with monoclonal antibodies. These are given as an outpatient. So early detection and diagnosis is still of the essence. Like I mentioned, part of the epidemiology. And now we have 2 newer drugs that are hopefully, if they're given early within 5 days, most like the same thing with Tamiflu and influenza. This one is from Merck, molnupiravir, and Pfizer, Paxlovid also came out. They're still asking, at least in the United States, for FDA, EUA approval, but we're still now having a drug that is targeted to the disease. So I hope that at least half hour that we've spoken, you've learned some lessons that, and I've been able to share some lessons that we learned from this pandemic that we are still learning because it's still not over. But as we prepare, what will the next pandemic be? Is it going to be viral? Is it going to be something else? How will it be? How will it behave? And this is where you need your think tanks. There are global organizations that are asking these same questions. How will it be? Planning different scenarios so that they can be prepared and help other countries and governments to be prepared for this pandemic. When will it be? We usually talk about every 100 years, but as we can see, there are several events that have happened throughout the world that don't take 100 years. So I don't know if this will take another 100 years for another global pandemic. Probably it'll be earlier and we'll be seeing it. So where will it start? Where will it be? These are the questions that we need to ask ourselves, applying the lessons we've learned and being better prepared for the future. Thank you very much. Have a good day. And thank you, Mega, for allowing me to be part of this.
Thanks, Glory, for your nice presentation, and it's very comprehensive, and it was actually inspiring also the experience of El Salvador to control the intensive care unit through telemetry. We would think about this, I think, everywhere now in our countries, and it gives also some backup plan in case if there is again any pandemic and you don't have enough staff. I have one question for you from Mohammed Suleiman. He's asking, what do you expect from the new variant of COVID?
We've spoken about that, right? And so what do I expect? We need to learn more. We know that this variant has several mutations in their spike protein. So it's a little bit more aggressive. We know it's highly contagious. The one thing that we don't know yet is how does it respond to the vaccine? So are the current vaccines that we have, that we hopefully all of us have received, will it protect us? And remember, the vaccines, even if they don't prevent you from getting it, it does, the numbers, what they say is that they prevent you from the severe disease, from hospitalization and death. So from a global perspective, that's still a good thing. And that's how we should focus on this. Similar to influenza. Influenza is still there. But with proper vaccination, then your cases go down. And if you get the disease with the medications, you prevent these hospitalizations and deaths. So I think that should be one of the things. And like I mentioned earlier, if we don't vaccinate and do an equal distribution of vaccination throughout the world, we're going to be seeing other mutations. And from what we've seen, there will be one that's more contagious than Delta. We don't know if Omicron, but there will be another one.
Yeah, thanks. There's another question. Can a patient be infected with 2 variants of COVID at the same time? Have you ever been through this in your experience?
I have not. But it would be, thinking if while you are infected with one, you're having an immune response. So usually that should prevent you from getting infected with another, with COVID again. Usually if you're infected, they tell you even to wait a little bit to benefit from that immunity that you get, that natural immunity you get from your infection. To be infected with 2 variants at the same time, that would require that the variant that infects you the second time around has evaded your immune response. So I guess theoretically it could be possible, but I have not heard of a case. Remember that for this also, you need to do sequencing, and not all the countries have that capability. This usually is done on research purposes.
I don't know, have you been to lockdowns in Puerto Rico during the first wave or not? I think there is some of the European countries here have been through lockdown, and others, they preferred just to continue open. And the data coming is just no big difference, to be honest, between the countries who locked down and the countries who didn't lock down in the numbers. And here in Ireland, with the full human activity nowadays, we still see the numbers are, infections and critically ill patients are still reasonable. And when you compare it, to the human activities happening now and everything is open. So I don't know how's the situation in Puerto Rico now, if any plan for lockdown, or have you been through lockdowns? Is there any difference? What's your experience in this?
Well, in Puerto Rico, the government stopped doing lockdowns unless there's a good collaboration within the Department of Health and also the economic. There was a medical task force at the beginning that gave their suggestions, and there was an economic task force, because you don't want to also be in lockdown so much that you halt the economy, and then you go into another problem with the country. So as the people have become more vaccinated, they have been analyzing which areas are of higher transmission. So obviously where you take your mask off, the restaurants, the nightlife. So what they're doing is they are restricting the hours. So there is I think it's from 9 p.m. or 10 p.m. till 5 in the morning, then you can't go out to the bars or something like that. And but now they're and they look at the numbers, and if the numbers go down, they open up a little bit more, and they see how and I think the country and the population has learned along the way that when everybody cooperates, then you get more liberties, and then you don't get locked down. So I think those are one of the things.
That's great. I think, well, I have a question here, but I think you answered already how to balance the economy with restrictions requirements. Yeah, it's just through selection of the counties that have higher rates and try to limit the hours, as you mentioned, and then reviewing the data coming and the updates, and then deciding accordingly. Thank you very much, Gloria.
Thank you very much. Thank you all for listening and for your very good questions.
Thanks.